Hi, this is Brooke, and today I'm going to talk about a case of ovarian hyperstimulation syndrome. And this case involves a 39-year-old woman, G2P1, who is 7 days status post an IVF embryo transfer. Her chief complaint was severe shortness of breath, where she could not take any more than 2 or 3 steps without being unable to breathe. She had abdominal distension and nausea without vomiting. Otherwise, her review of symptoms was largely negative. She did not have any vaginal bleeding, chest pain, leg swelling, cough, or any other GI complaints. On her exam, her vital signs were as follows. She was a little tachycardic, maybe a little tachypnic at times, breathing at 97% on room air. Her abdominal exam was mildly distended with moderate diffuse tenderness to palpation without rebound or guarding. Her lung exam had markedly decreased breath sounds on the right and also diminished at the left base. Her extremity exam was unremarkable. Her lab work was only remarkable for leukocytosis of 21, slight elevation in her HCG of 83, and otherwise her lab work was unremarkable. We performed a bedside ultrasound, and this is her right chest, where here, this is the liver, this is the spine, and an enormous right-sided pleural effusion. You can even see it swirling here. And this is a good example of the spine sign, where normally past the diaphragm you would not be able to see the spine, but here you can see it very well. On the left side you can see a smaller pleural effusion here. And further interrogating the right upper quadrant, here's the kidney, the liver is here, and the Morrison's pouch does not seem to be very convincing of free fluid, but this is a perfect example of why it's so important to look at the inferior pole of the right kidney, because she has significant fluid here and it's only seen at the inferior pole. This is further interrogating the left upper quadrant, and here again you can see the left-sided pleural effusion, but you also see a lot of free fluid underneath the diaphragm, between the diaphragm and the spleen. Again, this is a great example where the splenorenal space looks pretty clear, but you can miss a significant amount of free fluid if you don't interrogate the space between the spleen and the diaphragm. This is her pelvis, and the clip above focusing a little bit more on her right adnexa, where you see large ovary and multiple cystic structures. And here at the bottom on the left, you can see her left adnexa is the same. So on both sides she has these huge ovaries with multiple cystic structures. So this woman met the criteria for ovarian hyperstimulation syndrome. And it's not something we see very often in the emergency department, but it's an iatrogenic complication that's seen in 3 to 6% of women undergoing assisted reproduction. And the symptoms and the manifestations are due to increased vascular permeability that leads to third spacing of fluid. And it's a large spectrum of disease where it can just be enlarged ovaries and mild abdominal pain, all the way to pleural effusions, pericardial effusions, thromboembolic events, ARDS, and death. And OHSS is classified on severity based on how severe the clinical manifestations are. So what is OHSS and how does it begin? So basically any woman that's going under IVF or intrauterine insemination, they are given these exogenous hormones that cause ovarian stimulation that increases follicle production in the ovaries. So this creates ovarian enlargement, and the follicles in the ovaries secrete VEGF, or vascular endothelial growth factor, and VEGF is what is implicated as the culprit that leads to third spacing of fluids. To further complicate things, exogenous HCG is administered to women who are undergoing reproductive assistance, and that further leads to ovarian stimulation for the final step in oocyte maturation. And if the woman actually becomes pregnant and the IVF is successful, there's even more HCG. So then there's more VEGF secretion, and so on and so forth. And sometimes it gets way out of control, leading to these symptoms. So for this patient, she was admitted to the OBGYN service. She had a thoracentesis of her right side, which put out 1,500 cc's of straw-colored fluid. She was discharged, but just represented less than 24 hours later because she was having worsening shortness of breath, worsening abdominal distension, and her right-sided pleural effusion had just reaccumulated. So she had 2 additional thoracenteses. One was 1,200 cc's, 1,900 cc's, and they left about 3 liters behind in her right lung. They did not take everything out. So then she was discharged home with IVF clinic follow-up. So some take-home points from this case: always consider OHSS in patients with a history of IVF. Obviously, a woman of childbearing age and a woman who's pregnant has a very broad differential and can be many, many other things, but should also be added to your differential. VEGF is thought to be the culprit in third spacing of fluid, and OHSS is a huge spectrum disease and has various ultrasound findings, and you may find any of these things. It could just be enlarged ovaries, free pelvic or abdominal fluid, pleural effusions, and as in this case, you're more likely to see right-sided greater than left-sided pleural effusions because the left side has better lymphatic drainage. So there are a few case reports out there where women with OHSS just have a huge right-sided only pleural effusion. Sometimes you can even see a pericardial effusion. So visit our website. If you have any questions, just email us and we'll be happy to answer them. Thanks so much. Bye.